myself. I am Dr. Nitin Juneja. I am practicing orthopedic surgeon, and I have an interdisciplinary qualifications from IIM Ahmedabad and IIM Bangalore in healthcare finance strategy and you can say that management, insurance, and unlike my predecessor, I love cost economics. Okay, and with the permission of the chair, the topic which has given to me is the cost economics, finding balance for provider and the insurer or payer. I would like to add a word, finding balance for society and for all. I think this would be a justice to the topic if we talk in the language like finding balance for society and all, not for only the two stakeholders. So with the permission of the chair, I am going ahead. Just to give you a brief idea about India, this is 2014 data of what NSSO said. We had an 18% of the coverage. And with the present data, I think we have not moved beyond 25% of the health insurance coverage. And as you see that most of the coverage is by the government funded schemes, and the private insurer provide a smallest pie in that. And this is 2015 and 16 data. We have the 25,000 premium we have received as an insurance premium. Out of that, 90% of the premium was from the private and the group insurance sector, while from the government sponsored health scheme, only 10% of the premium has come to the kitty. And when you take the persons registered under the health insurance, you will find a difference. 90% of the premium is coming from the 24% of the population. That's the point we should look at. 76% of the population is giving you only 10% of the premium, and we are running this industry. And just to have a look at the government expenditure rates, in the last 2014, you can see that the total expenditure to the health from the government side is 1 lakh crore. And you can say that in the RSBY, that's what penny is coming to the health insurance pie. That's in the 2013, that was a maximum, 2013, that was a 1500 CR, and in 2014, it was 725. So look at the difference of cost economics here. Look at the money that is coming on the table for the people. This is, I would like to have you a very strong look at this graph, that whatever that per capita insurance is coming from the private insurer, private person is giving you a premium of 2,600 rupees, while the government premium, government sponsored premium is 89 rupees only for the year 2015 and 16. And likely in the group insurance, you have a 2,039 rupees per capita insurance premium coming to the table. So this is the kitty, and the hospitals are treating patients from all the kitty. And Indian hospitals and doctors need to be really a magician. How you can serve a patient with a cost difference of a 40%, 40 times you can say, it's not 40%, it's a 40 times. You can see there a 90 rupees premium we are serving on the government sponsored schemes. In the private health insurance side, we are serving the people at 3,600. That's a premium difference of 40 times. So I would like to put some of the facts of the economics in front of the forum so that we can find the common solutions. Now, whenever I have shown this graph, after this, I would be coming to this graph. This is from a US industry. And we would be following this path until unless we understand what is happening in India. There's a first graph that is showing that first come to the baseline, that's the 100%. The 100% area shows that where hospital recovers its 100% cost. Okay? That means no profit and no loss business for a hospital. And the underlines of a Medicare and Medicaid shows that US government gives approximately 80% of the cost of the hospitals as a reimbursement. And the second graph, if you extrapolate and the two similarities or dissimilarities, you can say, whenever government underpays the hospital, there is an increase in the private payer area. You can see that. You can see the gap. Whenever that the Medicare is underpaying, the private payer is paying more in the 120-130% area. So this will happen, and this would be an industry norm until unless we find a solution for the problem. So, and we don't have a data for an Indian industry, but we will follow the path. I will, in the economics, I like to start with the data. So some of the data from the NSSO, that we have a hospitalization rate which is increasing in India with thanks to the insurance, ranging from 3.2% to 6.8%. This is our hospitalization rate, 2014 NSSO. And average medical cost of medical expenditure in hospitalization. Mind you, industry has a confusion that it is a cost. No, please understand, it is a medical expenditure. It's not a price, it's not a cost, it's a medical expenditure. And this is what I got it from one of the, you can say that, newspaper cutting. Public have a confusion that what's the medical expenditure, what's the price, and what's the cost. But whatever we get it from the NSSO from the India, that we have a CAGR of almost 10 or 11% in a hospital expenditure side. Mind you, it's not a cost, that is wrongly projected in the media as a cost. And this is a total expenditure for the, you can say that the childbirth, NSSO says, and these are the various average medical expenditure happening in the various categories which NSSO project. That's 2014, that's 25,850 on an average per hospitalization is costing at 2014. And if we take a CAGR of 11%, we can calculate the average hospitalization medical expenditure on this, that of the day. Let's come to the definition of health insurance. Health insurance is a contract where, for a specified consideration, one party undertakes to compensate the other for a loss relating to the health elements of a particular subject as a result of occurrence of a designated hazard, like hospitalization. This is the definition of health insurance. On a lighter note, let's understand that health insurance is a financing tool. It's not a political or a profit or loss making tool. I am putting the word profit or loss making tool. I wanted to put one example of an ESI. I think we all know they are sitting on approximately cash of 30,000 CR. 30,000 crore CR ESI is sitting on. And as a private player, you are losing on a claim ratio of 110%, 120%, whatever may be the industry. That's a dynamic phenomena that is happening. Let's define the cost. Cost is the amount of money that a person spends on a creation of or production of a goods or a service. It's a monetary valuation. It's a monetary valuation for effort, material, resource, time and utility consumed. It's a risk incurred. It's an opportunity foregone for that money. Opportunity foregone, and mind you, it does not include the markup profit. It's a sustenance. There are various types of costs described in the market. One, the most commonly used, is the accounting cost, which you can get from your balance sheets, which your chartered calculates, and which is basically a historical outlay of fund. It's, you can say that, which we, in a healthcare service delivery, which is estimated by a cost allocation report. But the economists look at the cost in a different angle. Economics cost, just to explain you, if you are a seller, if you are buying something from a, you can say that wholesaler for rupees 100, for which you incur a cost of 10 rupees of a transportation cost. Then economists will consider this 10 rupees as their economic cost, and the pricing will evolve over that. So the idea is, whenever there is a costing happening in the healthcare, the economic cost needs to be considered rather than an accounting cost. And there's one more concept. There is a transaction cost economics. Basically, this transaction cost economics that includes the actual monetary cost. Then it includes the expertise, flexibility, risk, asset specificity, the cost of managing the relationship, supplier setup, switching cost, cost of bureaucracy, it is a hidden cost, integration cost, which is a hidden cost that should be known to anybody who is dealing on the cost economics. And to put you one more prospect, that cost is a function of behavior and approaches to the contract that can impact. You can say that your contract, your behavior, or your approach can change the cost behavior. Let's come on to some of the classical finding of the characteristics of the healthcare services on an economics perspective. To mind you, of whatever that these literatures are coming, these literatures are coming from 3 or 4 Nobel laureates, award-winning cost phenomena. These are the things that are coming from that side. So the economics perspective is healthcare is a very complex domain. It's a social need. There is an information asymmetry. There are moral hazards. There are adverse selection. There are mono or oligopolization of the provider. There is a presence of externalities. There is an imperfect competition in the market. There are market failure. We are living in the market failure in a healthcare services in India, and we are surviving here. The system do not operate in the Pareto optimum. Those who are from the management side, they can understand that what the Pareto optimum. Pareto optimum says that that's the equilibrium where social good and self good are on equilibrium side. This sector is influenced by political, social, economical, and technological environment as well. And there is a concept of inefficiency of the state. Whatever actions the state takes in that area, that percolates onto the negative spiral in some other area. The most important causes of increasing healthcare spending in all of the world, that's aging population, technological advancement, and increasing expectation of the society. These are leading to the cost changes. Now let's come to the behavior of the various stakeholders. There is an intrinsic information asymmetry. There is a power dominance area that is happening in the market with regulator, hospital, or the other providers. You can check. There is a power dominance case. There is an asymmetric information. So the market in which we are operating is not a perfect one or the ideal one. It's the imperfect market we are operating ourselves. Let's come to the 4 P's, or the 4 stakeholders in this value chain, health insurance value chain. The policyholder, payer, provider, or the patients. And the policymakers set the contacts, payer makes the procurement, and provider and patient are involved in the care provision. Policymaker regulates the coverage and leads to the, you can say that, leaves the expectation of the patients or the society per se, regulates the provider. And in the payer provides the, you can say that, the financial part, intermediary, providers perspective. So there are lots of perspectives that are coming on here. So let's understand that. This slide I just want to put the same data seen from a different perspective from the 4 P's. The perspectives are different. So you should understand that we would be living in the world where perspectives would be different. Providers' perspective would be different, purchasers would be different, and patients and society would be different. And I would like to invite all the forums, all the participants to just discuss the shared perspective, that where we have the bullseye, where we can work on. This is the cost perspective of the providers, insurer, society, and the government. Just we can have different views on the different you can say that areas. In the cost perspective, government wants all sides to be included on this perspective. Insurer wants that whatever they have signed the agreement on, and provider also, they have all cost perspective. So whenever we are talking about cost, we have to understand that cost perspectives are different, and your cost estimation criteria, my criteria, and any other body's criteria could be different. So we have to come to the common platform until when we go for the cost. In a perfect market where there is all the informations are there, transparency is there, market price is defined by the intersection of demand and supply. This is not the case with the healthcare. Healthcare is an imperfect market. We are working in a market failure state. So this criteria doesn't hold true in a healthcare services as of now. So this is the graph just I want to put for the academic purposes, but it holds very true. This is you can say that how a self-interest, this information, how a self-interest of a player could hurt the system. And if we can get a time, I can go with the details of this graph, that what's the average cost for the system, what's the margin cost of the system, and what's the revenues for the system. All these are important facts when you consider it as a system as a whole. These are some of the videos that I wanted to put, but just for the narrating purpose, there are lots of things that are happening in the market, in the healthcare area. That's the prisoner's dilemma, that's the Nash equilibrium, self-interest versus common goods in the market, and economics of the Nash equilibrium and Pareto optimum. And there is a moral and ethical dilemma, I think, which madam has already put in the form of doctors, but I have put the moral and ethical formula in the cost economics. If we don't put the cost in proper perspective, there would be increasing moral and ethical hazards in India, symptoms of which are already visible to us. Let's find the root cause of that and eliminate that. Otherwise, we would be leading to the US situation with a 1.5% of the GDP expenditure, while they are having in the same problem in the 18% of the GDP spending. But mind you that we are leading to the same condition. I am seeing that is if we are seeing that. And just to have what's the costing exercise is, how we define a cost and how the healthcare costing has to be defined. These are some steps, these 10 steps you have to follow in the planning phase and in implementation phase. When you are planning a costing study would be in a bottom-up costing, which is the most preferred costing technology. And this is basically a micro costing technology which has to be preferred over the top-down costing which is happening right now. And these are some of the calculations, how you come across the calculation of this is the one graph I got it from the US industry. India needs to work on that side, the hospital expenditure components and their variation over the time in the form of inflation index. India needs a medical inflation index which should be updated at least yearly. Right now we have a medical information which is getting updated over a decade or at the government level. And let's come to the just the final slide, sir. Just to have the principles, we cannot come to the conclusion. Let's have a principle agreement on the finding balance. Outsourcing is a continuum. It's not a destination. It's not a destination. Let's find that whatever that contract is going on, it is a continuum. Develop the contract that create mutuality of advantage. Understand the transaction attributes. The more the bilateral dependencies are, the more need of preserving continuity would be. Use contract as a framework, not as a legal weapon. Develop safeguard to prevent defection. Predict alignment can minimize transaction costs. Style of contracting matters, so be credible, leave money on the table, and the most important, build trust and keep it simple. And these are some of the references. These are the references from the most of the, you can say that from the Nobel laureates. Hello. And at the last, I would like to put that if you destroy the free market, you create a black market. That's the Winston Churchill.